Iya, masuk Pak. इस टाइम म्यूट है इधर सुन। ए हेलो, म्यूट है तो उधर आवाज जा रही होगी।
म्यूट है तो आवाज कैसे जा रही होगी?
Hello, good afternoon, all of you.
This is the day that the Lord has made. We will rejoice and be glad in it. With this blessed verse, myself, Miss Angel Christian, MSc Nursing Tutor of Dinsa Patel College of Nursing, welcomes you all in this e-conference on the topic of recent trends in community health nursing organized by IQAC and Community Health Nursing Department, DPCN. A very good afternoon to all the dignitaries, faculties, and dear students. Now, let us take the privilege of listening welcoming remarks from our Vice Principal Madam, Mrs. Arpita Vaidya Ma'am, who will welcome each one of us in this today's e-conference. Over to you, ma'am.
Thank you, Ms. Angel. Am I audible?
Yes, ma'am.
Okay. Good afternoon and Jai Maharaj. On behalf of Dinsha Patel College of Nursing, it is my great pleasure and honor to extend a warm welcome to all of you in this virtual conference. I request all the participants to mute themselves. Ms. Sandhya Kumari, please. Sorry for interruption. Good afternoon and Jai Maharaj. On behalf of Dinsha Patel College of Nursing, it is my great pleasure and honor to extend a warm welcome to all of you in virtual conference on recent trends in community health nursing. And this conference is organized by Internal Quality Assurance Cell and Community Health Nursing Department, Dinsha Patel College of Nursing. I warmly welcome Professor Virendra Kumar Jain, sir, Principal and Organizing Chairman of this conference. We feel enthusiastic by your presence, sir. I welcome you, sir. I warmly welcome today's resource person of virtual conference, Mr. Siddharam Sarate, sir, Head of the Department of Community Health Nursing, Manikaka Topawala Institute of Nursing, Charuset University. I welcome you, sir. And Mr. Iranna Arjun Kajagar, sir, Head of the Department, Community Health Nursing, PP Savani School of Nursing, Member Secretary of Ethical Review Committee at PP Savani University, Surat. I welcome you, sir. I welcome Mr. Kailas Nagar, HOD, Community Health Nursing Department, Dinsha Patel College of Nursing, who have been actively associated with initiation and organization of this conference. I welcome you, sir. I warmly welcome Organizing Secretary, Mr. Jyot Darji, sir, and organizing members, Ms. Angel Christian and other members of Community Health Nursing Department, Dinsha Patel College of Nursing. I also welcome the students and faculties of various nursing colleges. Once again, I welcome you all in this virtual conference. Thank you.
Thank you, ma'am. Now, I request all the delegates that if you have any queries or doubts regarding any session, then you are requested to write any questions in the chat box, or you can ask at the end of the session. Trends in nursing profession are closely related to those in medical profession. The era of specialization and biomedical science have far advanced, resulting in newer diagnostic equipments and drugs in the field of healthcare and all over the area. The healthcare system and the nursing profession is expanding globally. Therefore, it is important for nurses to know the trends, issues, and the challenges in new millennium. To upgrade our knowledge in this topic, we are glad to have the experts with us. Now, we are going to move on with our first session on the topic of community nursing towards sustainable health, in which we have today with us our expert, Mr. Iranna Kajagar, sir, who is the HOD in Community Health Nursing, working at PP Savani School of Nursing, Surat. Sir has completed UG and PG at KLE University, Karnataka. Sir has expert knowledge in the field of community and many other areas. Sir has also done many research paper presentations in national and international conferences and journals. Sir has total 12 years experience in the field of nursing. Sir has also organized many national and international conferences and workshops. Sir has received Best Teacher Award in the year 2019 at Parole University. Now, I request Sir to take the talk and move on with our first session. Over to you, sir. Due to some technical errors, Sir is not able to join. Please stay continued and connected. Sir will join us in few seconds. Yes, sir, you can continue with that session. Sir, please share your PPT. Your voice is not audible.
Yes, sir, audible.
Sir, your voice is not audible. We are not able to listen anything. So your video is completely visualized, but your voice is not coming. So slides we can see, but your voice is not coming. Sir, you are on mute. Yes, sir. Now we can hear. Again, it went off. Sir, you are on mute, sir.
Please unmute yourself.
Yes, sir. Now we can hear. Excuse me, sir. Sorry for the interruption. We can hear your voice, but not clearly. It is not understood. No, sir. It is not coming. Some disturbance is coming in between. Okay, sir. Excuse me, sir. We are not able to listen again, and some kind of disturbance is coming in between. It is not audible properly. It is not clear. Yes, sir, we can see the PPT, but in between your voice is just disappearing and not able to listen properly.
Sir, sir, is I am audible?
Yes, sir. Now we can hear you.
Hello.
Yes, sir. Now you're audible.
Okay, okay. Okay. Yes, yes, thank you. So there are technical issue. So by seeing the definition, we can say that health is heavily influenced by the factors outside the domain of the health sector, economical and the political forces. Thus, we can say that the attainment of the highest possible standards of health depends completely on the comprehensive holistic approaches, and which goes beyond the traditional, that is the curative care, and it involves all the communities and as well as the healthcare providers, including the nurses. When you speak regarding the health, and definitely
Excuse me, sir. We are not able to listen to you. And all the participants, please stay connected due to some technical issues. The video and the audio both are not connected properly.
Hello.
Yes, sir. Yes, sir.
Okay. So what is the need to achieve it? So what is the need to achieve it? So to achieve that sustainable health, we should have that strong, efficient, well-grounded health system. So we should have a proper health system. That health system can deliver the health services to all the needy people.
ओके ये लिखा है सर उसका ऑप्शन क्या है
Madam, I am audible now?
Not properly, sir. Sometimes it is audible, in between again the disturbances is coming. And the slides are not moving at all. It is constantly the same first slide.
Is I am audible now?
Yes, sir. Now we are audible.
Yes. Yes. So how it can be achieved? So we should have that strong, efficient, strong way. Madam, slides are, we can see my slides. I am sharing the slides. Okay.
Due to some technical errors, now we will continue this lecture after some 1 hour. Now we are going to continue with our second lecture. So we will see about that. Now I invite and welcome our today's resource person, Mr. Sidram Sarte sir, who is the assistant professor at Manikaka Topawala Institute of Nursing, Changa. Sir is appointed as member secretary in Institutional Ethics Committee, Charuset, serving as a member of Research Council Cell and Human Resource Development Cell at Charuset. Sir has published more than 15 plus research papers in Repute and Human Resource Development Cell at Charuset. Sir has organized many national and international conferences and workshops. Sir has been invited as chairman, speaker, and a panelist in many conferences held at Charuset and different colleges. Sir has also received 2 Best Research Paper Awards by Charuset in the year 2020. We are very honored by your presence, sir. Now I request sir to please over and take the session with you. Over to you, sir.
Thank you, ma'am. Is my voice is audible?
Yes, sir, you are completely
That's
audible.
great. At the outset, let me take an opportunity to thank the management of DPCN, Principal Virendra sir, Kailash sir, and Dod for inviting me for talking on topic health policies and recent programs. Right, sir, ma'am, can I share my PPT?
No, sir. Now it is not visualized.
No,
You can-
I did not get your rights. Can you give me rights?
Yes, sir. We can hear you properly.
I hope it's audible.
Yes, sir. Yes, sir. Slides are also coming.
Okay. Actually, I was asked to talk on health policies and recent health programs in India. I think I request participant to mute yourself. Katari Kanta, can you unmute yourself?
Participants are requested to please unmute yourself. Please mute yourself.
Shall I proceed, madam?
Yes, sir.
I was asked to talk on health policies and recent health programs in India. It is actually a very good topic I was asked to talk. Why it is very important to understand health policies. What is, it is started the history of developing health policies in 1946. It is very important to strengthen the health infrastructure, improve the health status of public citizens. When you look at inequality in the world, 25% of world population enjoys 75% of its wealth. So only 25% of world population enjoy 75% of their wealth, and 75% of world population live in developing and underdeveloped countries. So it's one of the major inequality in the health. And we have one more 10 to 90 gap. So that means 90% of world resources are enjoyed by 10% of the countries. So if you look at the resource utilization, 90% of resources are utilized by 10% of the world countries. And if you look at per capita spent on health, US is the one of the top country. It spends $9,451 of their GDP. Still, it is not number one. And Norway is not top 10, comes under top 10 countries where they spend on health of their GDP, even which is not there in the top 10. But still, it is first in the Human Development Index. So the question is, spending money on health infrastructure may not help you to achieve a good health of your people. So it is the utilization of health resource. So India, it is in 130 first in the HDI index, Human Development Index. Mein India 131 position mein hai. But when you look at expenditure, it is at the 151st rank. So on the expenditure, so India spends only 1.28 of their GDP on health. So even it is appeal of the healthcare professionals, experts to spend at least 2.5% on health, so that we can have a better health infrastructure and better health resource utilization. So let me proceed with my next slide. Madam, slide is changing.
Yes, sir.
All right. So in introduction, health system and policies have a critical role in determining the manner in which health services are delivered, utilized, and affect the health outcomes. So the very important is the health system and policies. And when you look at planning, so I'm not going to talk much detail on the planning. So here when we plan any programs, any schemes in the country, first they will do the community health problem survey. They define the health problems. Maybe it is non-communicable disease, maybe it is communicable disease, maybe it's emergency disease, pandemic, epidemic, whatever. That they will define it clearly, and they will assess the unmet needs. If there are certain needs to be met, if it is not unmet, it is not utilized by people, what is the reason? What are the resources or schemes are not met by the people? And then they do the survey of resources. Then accordingly, they establish the goals. Then the proposal of action. So any health programs we discuss, Janani Surasya Yojana, you talk, Indradhanush Yojana, you talk, the problems talk. So it go through this process. They define the problems, they identify the needs, unmet needs. They do the survey of resources. Maybe it is money, maybe it is equipment, maybe it is material. Then they establish the goals. Then they propose the kind of action should be taken. So how health planning in India started? So there are what are the different roles of different committees? Any committee you talk, any health policy you talk, the first thing comes into our mind is board committee. So that's the strongest recommendations we received so far. That was established in 1946. So that talks about integration of preventive and curative services of all administrative levels. So that was the first recommendation given. So integrating preventive and curative services. Preventive, I hope everybody able to understand the preventive services. Then curative is when patient get admitted to hospitals. And development of primary health centers in 2 stages. They have given 2 stage criteria how to develop primary health centers. In short term, they given 1 primary health center as suggested for population of 40,000, and secondary health center to provide support to PHC to coordinate and supervise their functioning. So now it is 25 to 30,000. Still many PHC serving for 40,000 population, and each primary health center constitutes around 6 to 8 sub-centers. In long-term program, so he suggested setting up a primary health center unit to 75 bedded hospitals for each 10,000 to 20,000 population. So the long-term program in 1946, he suggested for every 10,000 to 20,000 population, there should be 75 bedded hospital. I don't feel this century we could achieve this, because so far now our primary health center consists of 6 beds, right? So in a referral hospital have 30 beds as of now. So long to go now. So again, they said second unit with 60 bedded hospital and regionalized around district hospital with 2,500 beds. The major changes in medical education, which include 3 months training of preventive and social medicine to prepare social physician. Maybe you are very aware. Government of Gujarat also come up with the scheme like once they complete the MBBS compulsory, they should serve a rural area of 2 years, I guess. If they break, they have to pay some amount too. That means they should get an exposure to the preventive measures, not about the only curative measures. And creation of measures Central Institute for Postgraduate Medical Education and Research. The more importance was given to the medical education, especially postgraduate medical education and innovation and research. So that was a recommendation of board committee, and next was the Modalia Committee. It came in 1962. So this was to strengthen the PHC sub-regional and district hospital. Actually, this committee is made to how the progress of the board committee's recommendation. What was the extent we achieved? So the first thing is to see the strengthening of the PHC sub-regions and district hospital, improve the quality of healthcare provided by primary health centers, especially curative, promotive, and preventive measures. Strengthening the district hospital specialist. So there are many district hospitals don't have the specialist like endocrinologist, maybe ophthalmologist, maybe pediatrician. So specialized services should be available. Creation of all India health services. So again, we had one more committee called Chada Committee, 1963. This committee suggested that vigilance activity in National Malaria Eradication Program should be carried out by basic health workers. So during this year, malaria was an epidemic, and Dr. Chada was a malariologist. So he was asked to give a recommendation. And that time he given a recommendation, there should be one basic health worker for 10,000 populations, and who would function as a multi-purpose worker and would perform, in addition to malaria work, the duties of family planning, vital statistics, data collection under the supervision of family planning health assistant. So already family planning was in force, that welfare program. Along with that, the basic worker can serve one for 10,000 population. So she will take care of activity of malaria and other activities too. Next, we had a Mukherjee Committee, 1965, and this committee recommended to de-link the malaria activity from family planning so that later it would be received undivided attention of its staff. So Mukherjee came up. He was working for family planning. So this committee suggested those the basic health worker working for malaria, let them work independent to malaria, not work for a family planning. Because if you de-link, so the seriousness of these activities would be there in the healthcare. So that was, he said, this should be de-linked. The committee recommended separate staff for family planning program, and basic health worker were to be utilized for purpose of other than family planning. So this basic family so they can work for other than family planning. So they need not to involve in family planning programs. Again, in 1966, again Mukherjee Committee worked out the details of basic health services, which should be provided at the block level. Some sequential strengthening required at the higher level of administration. So we had Jungalwala Committee, 1967. So it's audible?
Yes, sir.
All right.
It is audible.
So it was asked to look into various problems related to integration of health services, abolition of private practice by doctors in the government services, and service condition of doctors. So this was a major recommendation given by him. So those earlier, the doctors who were working in government hospital, they used to do private practice, and more focus was not given in the government sector. So he brought the policy where if they are already working for a government, they cannot practice independent. Even he given recommendation, the working condition of doctors should be improved. So it was well recommended, and it was put into force. Now I think no doctors can practice independently if they are in the government. The most important committee was the Kartar Singh Committee in 1973. It talks about multi-purpose. That means those are earlier what family planning, there was a health assistant. Malaria, there was a health assistant. The different health programs, there were health workers. So he come up with the multi-purpose workers concept. That under health and family planning is considered a framework for integration of health and medical services at periphery and supervisory level. His recommendation was various categories periphery workers should be amalgamated into single cadre of multi-purpose workers. Now we see in community multi-purpose worker, male and female. This is the concept given by Kartar Singh in 1973. So these people, first by auxiliary nurse midwives were to be converted into multi-purpose worker, male or female, and the basic health worker, malaria surveillance workers were to be converted into multi-purpose worker, male. So these are two categories he made. All the auxiliary nurse midwives will be converted into multi-purpose worker, female. Those were basic health workers. Those are looking into malaria surveillance, family planning. So they has to be converted into multi-purpose worker, male. And that is what we have right now. So this work of 3 to 4 male and female workers was to be supervised by one health supervisor, that is male or female respectively. The existing lady health visitor were to be converted into female health supervisor. So each subcenter are headed by this female health supervisor. So she will look into 3 to 4 multi-purpose workers. She will be at the monitoring level, so supervisory level. So one primary health center should cover a population of 50,000, and it should be divided into 16 subcenters, one for 3,000 or 3,000 population, each of to be staffed by male or female health workers. So now it is it says 16 subcenter, but if you currently look at our working pattern in community periphery, so each primary health center covers 6 to 8 subcenters. So Srivastava Committee, it talks about 1975. Determines steps needed to reorient medical education in accordance with the national needs and priorities. So anytime it happens, even nursing curriculum, which is designed in 2006, yet it is not revised. bachelor degree program. Now they brought into semester. Still, it is the draft level. Few of the university has adopted at second story. But same thing, even in the medical education, it was not oriented according to the national needs. So he has commented the medical education should be as per the national needs and priorities. So next he said is development of curriculum for health assistant where to be function as a link between medical officer and multipurpose worker. It recommended immediate action. So why that is immediate action? One is creation of bonds of paraprofessionals and semi-professional health workers from within the community itself. So they suggested so there should be a health assistant between the medical officer and multiple health worker because 3 to 4 multiple health worker will not be able to serve the population, said population. So they said there should be someone to support them. So that is what they said is health assistants. So they recommended, so these posts can be created, these paraprofessionals are semi-professionals from the community. So what we have is ASHA. It is from the community. So that was not the new concept. It has come in 1975. Later, NHM has adopted this concept. Establishment of 3 cadre health workers, namely multi-purpose health worker, health assistant between community level workers and doctor. That is what he done. Development of referral services complex. So the CSC is one of the first referral unit in the periphery level. So it has to have all the facilities. Establishment of medical and health education commission for planning and implementation reforms needed in health and medical education on the line of university grant commission. I hope most of you are aware. Still, Gujarat don't have a medical university. It is suggested that each state should have a separate medical university. So, like Karnataka, we have Rajiv Gandhi University of Health Science. In Maharashtra, we have Maharashtra University of Health Science. And now at MP, recently they have established health universities. But still in Gujarat, we don't have. So they said there should be a medical and health commission. So they should work in the line of university grant commission. They direct the health and medical education. So still that is need to be improved. So hope soon Gujarat may have one medical health medical education university. So this is the last committee, Bajaj Committee, 1986, formulation of national and medical health education policy. So they talk about there should be national medical and health education policy. So far we have health education policy, we have health policy, we have. They were saying there should be national medical and health education policy and formulation of national manpower policy. So that means there should be a registration what we have. There should be job allotment. So that there should be a national health manpower policy. And there should be establishment of education commission for health sciences in the line of UGC. Again, he recommended the same. And establishment of health science university in various states and union territories. Each union territories, each states should have a separate health science universities. That is not there in all the states. In Gujarat, we don't have. Establishment of health manpower cells at center and the states. So these are all the foundation given for developing national health policy in 1983. What is the role of these committees? These suggestions, recommendations are led to bring national health policy in 1983. One was Board Committee 1946, Alma-Ata Declaration 1978. I hope everybody are clear about Alma-Ata Declaration. Health for all. Yes. I hope participants are aware about Alma Declaration 1978, which talks about health for all. This is a constraint of virtual learning. No participant will be active. So in Alma-Ata Declaration 1978, we come up with the health for all 2000. By 2080, everybody should have a good health. Then we come up with the National Health Policy 1983. So these three concepts, Board Committee, Alma-Ata Declaration, and Health for All, made us to bring National Health Policy 1983. This is the first health policy in India. So these are all the foundation for bringing up this. And what Alma-Ata Declaration talks? International Conference on Public Health took place in Alma-Ata, Kazakhstan, which was a major milestone in the field of public health. Why? because India was too participated in this conference and became a signatory to the Alma-Ata Declaration Committee to provide health for all by 2000. Earlier, India was not a signatory authority. Now it became a signatory country, and we joined hands to achieve health for all by 2000. And it is to realize this goal, first ever health policy was formulated in 1983 with a goal to provide health for all through primary health center. To achieve health for all, and that is through primary health care, this 1983 health policy was brought. So the major cause for bringing this is Alma-Ata Declaration. So what it talks? National Health Policy of 1983 was announced during the sixth plan, the 5-year plan. It recommends universal, comprehensive primary healthcare services which are relevant to the actual needs and priorities of community at the cost which people can afford. So that where there is an inequality, many people, health is a right of an individual to be healthy. It's a right. When you are sick, it's your right to seek a help of a healthcare professional. It's a human right, right? So what they suggested is it should be universal. Health services should be given to everyone. It's a comprehensive. That means all the aspects should be covered at the primary health services, and it should be relevant to the actual need of the community, and it should be as per the priorities, and people should be able to afford it. And this policy said that India is committed to attaining the goal of health for all by the year 2000 through the universal provision of comprehensive primary health care services. When I talk even in 2017 health policy, it is also talks about comprehensive primary healthcare services only context is different. Those 1983, the health issues are different, and now the health issues are different. But the concept is same, comprehensive primary health. So objective of this policy is 1983 is the main objective of this policy is to achieve an acceptable standard of good health among the general population of the country. So as now all of you are aware, it is a responsibility of the state, it's a responsibility of our country to ensure that everybody will enjoy their good health. When somebody is sick in the community, somebody is sick in your family, it is not the responsibility of a community or a family, it is also a responsibility of a state. It's a responsibility of a country. So that is what they look. So to have a standard, acceptable standard of good health, so they bought this policy. So everybody should be able to get a good services. So this was the proposed approaches for 1983 policy. One was decentralized public health system. That means in the periphery, every services, basic elements, treatment should be made available to every citizen. Next is increase aggregate public health investment. You need to invest more in the public. As I was saying, GDP, India is spending 1.15% of its GDP. It is very less. As I said, Australia is paying $9,451 of their GDP, and whereas India is paying just 1.5%. And the health expert says just to pay us 2.5%, we have a robust health infrastructure, and that has to be invested back. Enhance the contribution of private sector. Earlier, we don't had the public-private partnership. Now, most of you are aware that now GMERS is a concept of PPP model. Even most of the 50-bedded hospital compulsory offer certain schemes and programs. It is compulsory, government made. So that is what they're inviting. If you have 50-bed hospital, come forward. You take Aishman Bharat Yojana concept, you take RBSY, whatever the schemes, sign it, and that this will be given. Most of our hospitals are offering. Mukherjee Yojana, Vatsalya Yojana, it's made available every 50-bed hospitals. Next is rational use of drugs. It is very important because India is a home for many clinical trials. India is home for many pharmaceutical companies, and we are developing resistance to the antibiotics. And it's very important to use the drugs with rational. Don't take for everything antibiotics. That's what they say. Don't go for over-the-counter medications. So in a day, you may develop the resistance. It may have serious issues. So access to the tried and tested system of traditional medicines. In 1983, Also, government was insisting you to go for alternative medicines. What we talk about homeopathy, what we talk about Ayurveda, we talk about Unani, we talk about Siddha, but still people were not well oriented. It's good now in 2021, and this government has promoted Ayush. Much, we have Ministry of Ayush update. That means more importance is given to the preventive measures. So this concept was there in earlier also. This approach was proposed by the 1983 health policies. So reconstructing health services after 1983, one is focus on integrated services. Every one of you know that what is integrated services. That means when a mother comes to the hospital, our oral health would be taken care. If child is requires some treatment, some interventions, that have to be taken care. It should be integrated. So if these services are not available, there should be a referral unit. They should well connect with the PSC. Thus, all services should be integrated and they should be packaged for a family. When they come, they should not feel that I should go to other hospital. So that all basic services should be made available. Equip workers with knowledge, skill, and technology. It is very important. So probably it happens many times. You learn something different. That by the time you go to the hospitals, the practice mentality is different. It does not mean that you did not learn anything. It's like you need an upgradation. That is what now Gujarat Nursing Council, MCI, there are many other regulatory bodies come up. You should have minimum 150 credit hours to renew your registration. That means your knowledge should be upgraded. Then only you can continue working, or else you cannot be permitted to move ahead. I hope it's clear. It sounds well for everyone. Even it is made mandatory for for us. We have faculty development programs. Many sanitization program we have in government too. All the health workers are trained well time to time when policy changes, when program changes. It's very necessary, right? So next we have is establishment of well worked out referral system. So there should be a good referral system. So that's what now good. I think 2 days ago only I got to know that SRS report, and Gujarat is doing quite well. Maternal mortality rate come down to 70. So very nice per lakh. So that means we were doing well, and institution delivery has improved, and we have good referral system. So establish a national-wide chain of sanitary epidemiological stations and special and well-coordinated programs for differently disabled. These were the reconstructing health services of the 1983 health policy. Coming to the second health policy, that is 2003. Again, what are the contributing factors? Again, Board Committee 1946. Alma Ata election 1978, Health for All 2000, National Health Policy 1983, then come to the MDGs 2000. What is MDGs? I hope everybody are clear. This Millennium Development Goals, 189 countries met, and they have come up with the goals, certain goals, 17 goals and 169 targets, and till it was there for 2015 Millennium Development Goals. Later they have revisited, and they found there was a remarkable progress in health indicators by 2015. Then they thought, so they might have not achieved what it's supposed to be achieved, but remarkable progress were made. Then they brought the sustainable development goals. Sustainable. So we have made remarkable improvement. We should sustain that level. We should not come down. So now again, these targets are reframed, and now same 17 goals and 169 targets are given should be achieved by 2030. And now we bought a national health policy. Even there was missing is a national population policy. In 2000 we had national population policy too, and this all contributed to bring national health policy 2003. Board Committee, Alma-Ata Declaration, Health for All, National Policy 1983, MDGs, and this was supposed to be national population policy 2000. So this all contributed to bring National Health Policy 2003. So what it talks in this field of health, two important things happened in India in 2007. One is first time the Indian government announced the National Population Policy known as NPP 2000, and India became one signatory to commit to Millennium Development Goals. Very important milestone in Indian history of health is Pehli baar, actually India is the first country in the world to bring family welfare program in 1952. None of the countries have come. Still, we have second largest country in the world. Right? And second, the what is it became a signatory country to commit Millennium Development Goals. Hiral Panchal, can you mute yourself? Hiral Panchal. Thank you. After 2 years, India announced National Health Policies 2002 that reflects the concern of Millennium Development. So in 2000, they become a signatory country. So they brought the National Health Policy 2000. So this was the health-related Millennium Development Goals: eradicate extreme poverty and hunger, achieve universal primary education, promote gender equality and empower women. Participant, can you mute yourself? Reduce child mortality, improve maternal health, combat AIDS and malaria and other diseases, ensure environmental sustainability, develop a global partnership for development. These are the 8 goals which were directly and indirectly related to health. And most important is, if you look at poverty and hunger, it's not well defined. I was reading a definition of United Nations. What is poverty? So they very hard-touching definition was given. This is when a family, a person, where they deny the services, they deny the schemes. That means if you ask the children to send the schools, it is free of cost given. They say no, we cannot afford. Even the free of cost education they cannot afford. That means the child should contribute to that. That is called the extreme poverty, right? So what are the National Health Policy 2002 objectives it has? One is, it showed its concern for regulating the private health sector by creating a regulatory mechanism for introduction of statutory licensing and monitoring minimum standards. So this policy showed the concern regarding private health sector. So they should come forward and they should help, and they should also create a mechanism to introduce statutory licensing and monitoring minimum needs. So minimum standards. So the regionally that we have Gujarat Nursing Council, we have other councils, they have set minimum standards. So that was a concern. Second is, primary objective of this program is to achieve a reasonable standard of health among general population of country by increasing utilization of public health facilities from current level 20 to 75%. Remember in 2000, the utilization of public health facilities, that district hospital, taluk hospital, primaries, and this all government hospital utilize all just 20%. And now they're expecting through this program at least 75% of utilization. So now I hope we should appreciate current Prime Minister, and he oriented all of us to all the government health centers. Everybody, none of us denied. Everybody gone to primary health center. Everybody visited to government center and took an vaccine. And it first time it happened. Mostly everybody opt for private health facilities. And this time, first time happened, whole country gone to their nearest public health center and they got a shot. So that's a great thing. Now they are well oriented. This is National Health Policy 2017, changing context of health priorities. One is burden on account of non-communicable disease. So how it is changing, priorities are changed in 2017. Now the burden of non-communicable disease. Earlier, communicable disease were the threat. Now it become non-communicable disease are threat now, because many of the diabetic, hypertension, stroke, so many cancer. So all this non-communicable disease affecting the health very badly. So that was a major burden. Second is the emergence of robust healthcare industry. So now one change is we got robust healthcare industries where public-private partnership, where many services are rendered to the public. And third is growing incidence of catastrophic expenditure due to healthcare cost. Very important to understand here is the out-of-pocket expenditure is in India is 65%. मतलब जो 65% of people है वो लोग जो हेल्थ का जो हर उसका जो इनकम है वो 10% से ज्यादा हेल्थ पे खर्चा करते हैं. So that means that kind of people, how many out of 165 people, they spend more than 10% of their income every year, and it is very high. So that is what we are going to see, and what Ayushman Bharat Yojana talks about. So that is a part of your National Health Policy 2017. Rising economic growth. So it's good that economically India is sustainable and doing well. So what are the aims of National Health Policy 2017? I think we have enough time, right? I can go ahead with my pace, right, Jyot?
Yes, sir.
Yeah, all right, thank you. What are the aims of National Health Policy 2017? Inform, clarify, strengthen and prioritize the role of government in shaping a health system in all its dimensions. So it is, you have to inform a public what is the role of government hospitals, and to save the health system in India. So we have much more to do in government, and much more services are made available to the public. They have to utilize it. Investment in health. So as I said, already GDP only 1.15% to be spent on health, and the recommendation by expert is 2.5% of GDP. But good that we got the package Ayushman Bharat Yojana mein under we got an insurance scheme. That's the first ever happened in India that 5 lakhs package is given. So that will bring down this out-of-pocket expenditure drastically. So that will help. So millions of people, those are in above poverty line, coming down to below poverty line only because of out-of-pocket expenditure. Because a small family who are just above poverty line undergo a bypass surgery may spend 2-3 lakhs, and they go into debt and they get into the below poverty line. So this is one of the finest program India ever seen. Organization of healthcare services, integration of healthcare services, prevention of diseases and promotion of good health through cross-sector section, as now it is cross-section. Cross-section matlab we have Ayush in the picture now, homeopathy, then we have Unani, and we have many more alternative therapies. So if you work with those, that will be a great thing. It will help us to have a better preventive measures. Access to the technology, as everyone know now, techniques are changing. Now we are in the era of modern technology. We have telenursing, we have telemedicines. There are many hospitals come up, especially COVID and mental health, restoration of mental health. That is through telemedicines. So you have to utilize it. That was the intention of 2017. By the time we got COVID, and we got robust technology right now. Next is developing human resources, very important. No machines can replace, no robot can replace, no artificial intelligence replace a human. That is for sure. So we need to have a better qualified, skillful human resources, and we nurses are skilled professionals. Nobody can replace us, and we need to have a better facility. We require more facility, that's it, but nobody can replace us. So that was the intention of 2017 policy, developing a better human resources, encouraging medical pluralism. So that what is the medical pluralism? That is having the alternatives in the medical approaches, building knowledge base. Everybody's knowledge should be strengthened, developing a better financial protection strategies, as I'm going to talk about Ayushman Bharat in next slides. Strengthening the regulation and health assurance. So these are the few important aims of 2017. So what is the key principles? One is, I'll start with accountability. So everybody are accountable. Earlier, nobody were accountable at the periphery. Everybody says it's not my job, it is not my fault. Now everybody are accountable. Everybody need to work, right? Inclusive partnership. That means every private hospitals every private sector should come and work with the government. That's a mandatory. So that's a good sign. Pluralism, as I said, different alternative medicines should work for preventive measures. Decentralization, all services should be available in periphery. Dynamism and adaptism. So whatever the change, you have to accept it and have to adapt it, and new technology should be utilized better way. Professionalism, integrity, and ethics, very important. The only thing the ethics cannot be taught in a classroom. Ethics is when you assume yourself in the particular conditions and you feel what other persons do. That should be done by investors. So that is what we supposed to have a professionalism integrated with others, and ethic, equity. So equally, services should be equally given to everyone. And these are all there in the papers. I don't know how many people get equal services. Affordability. So people should be able to afford that treatment, right? So universality. So everywhere it should be services should be available. Patient-centered and quality. And very good now. Now mostly primary health centers are given national quality assurance standard, and it should be 17 above. Then only they'll get all the facilities. So few of our doctors which I was talking to, they got accredited with any. I hope everybody NQS standard is mandatory for all PHs. So mostly you may be aware. So this is all about key principles behind bringing 2017 health policies. What are the objectives? There are three important objectives. One is progressively achieve universal health coverage, which I was talking in 1983 health policy. The same we have is same health universal health services, health coverage here also. Only thing is priority have changed. So one is assuring availability of free comprehensive primary health care services, UPHC, universal primary health care services. All the services should be free and comprehensively it should be available at a primary health care services. That's number one. Second is ensuring improved access and affordability of quality of secondary and tertiary care services. So they should be easily accessible to the referrals. Quality of secondary and tertiary care services. When primary is preventive, secondary, tertiary is early diagnosis and treatment and rehabilitation. Those services should be affordable at the periphery and it should be reasonable. It should be affordable. Achieving a significant reduction in out-of-pocket expenditure due to healthcare costs, as I said, महंगाई बढ़ती जा रहा है, महंगाई ज़्यादा हो रहा है, तो उसके हिसाब से खर्चा भी ज़्यादा हो रहा है. So we need to have reduce the out-of-pocket expenditure. So that is what is a health insurance scheme that we are going to talk later. Reinforcing trust in public healthcare system. It is very natural that all of us, you or me, we never opt for government health services. When we sick, we go to the private. So we need to build a trust in the people so that they can come to the public health government hospitals. They can take care, seek care from the government. So that is missing. So that is the next responsibility of every people who are working in the public. Strengthening the trust of the common man in public health system. And next is align the growth of private health care sector with the public health goals. So when Jungalwala has recommended private government people should not practice. Now what is the second is private people should work for the government. They have to adopt some schemes, some programs. So that is very important. So that is your third objectives. Key targets of this policy is increase life expectancy at birth from 67.5 years to 70 by 2025. We have gone very ahead. When British left India in 1947, life expectancy of India was 27 years. That means the baby who take a birth can on an average live only for 27 years. So we have done dramatically improvement, but still the target is given 70. Almost we reached 69 now. So only 70 by 2025 we should achieve. We are doing very well. Reduce fertility rate to 2.1 by 2025 because population growth is one of the major setback for country. So we need to reduce the fertility rate at least by 2.1. It is now 2.3. So it should be 2.1 by 2025. Reduce infant mortality rate to 28. Gujarat, I think it is 30, I guess. So in 2019, probably we are at further targets. reduce under 5 mortality to 23 by 2025, achieve the goal of 2020 HIV, that is 1990 global target. Can anyone will be able to say what is this 1990? If someone say, I'll be happy. Achieve global 2020 HIV target, that is term 1990 global target. Anyone able to say it? Well, 90% of the people who are suspected should go to the healthcare facilities, get diagnosed. 90% people go to diagnosed. 90% should know their status of their viral load, and 90% should able to start antiretroviral therapy. So they know their status, they take an antiretroviral therapy, then they will have the viral load sustainability. That is what 1990 target. Everybody clear, I hope. Jyot, I am audible?
Yes, sir, audible.
Yes, sir.
Next we have is reduce the premature mortality from cardiovascular disease, cancer, diabetes, chronic respiratory diseases by 25% by 2025. So there are many premature deaths due to especially cardiovascular disease. It's one of the major concern now. It is happening now with the young age, between 30 to 45. It's very bad sign for a country. Youth should not suffer with such premature deaths. So it has to be extra precautionary. We have to take care of our lifestyles. So that was the target. Reduce the prevalence of blindness to 0.25 per 1,000 persons by 2025. Disease burden to be reduced by 1/3 from current levels. You have many disease burdens like hypertension, cancer, diabetes. Elimination of leprosy by 2018, Kala-Azar 2017, and lymphatic filariasis endemic pockets by 2007. Yeah, this is all about health policies, 1983, 2002, and 2017. So if you have any questions, I'll be able to take some questions, or else I'll go ahead with the Ayushman Bharat music. Moderator can, if you have something in the chat box, I can speak on that. I may not be having answer for all your questions, but let us have a learning discussion. Yes, Jyot, we have anything in the chat box? Any questions?
No, sir, no any.
No, sir.
All right, fine. So we'll start with Ayushman. This is a recent health program, and many of us got a confusion that Ayushman Bharat Yojana matlab 5 lakhs insurance. No, that is actually different. That is one of the component of Ayushman Bharat Yojana. So we'll see why Ayushman Bharat Yojana has come into picture with the objectives of to highlight the heterogeneity of healthcare system in India. That means heterogen ke matlab, as we said, no, 72% of people live in rural, and rest other will stay in the urban, or all health facilities is reverse. All urban health facilities are available at urban, and it is reverse. So that's a heterogeneity. So that need to be highlighted. You need to work, better services should be given. That was the first thing. Describe the evolution of primary healthcare in India. So why the primary health care has brought into India, and what is the importance? What is the evolution? How to strengthen it? That was the second. Key achievements and challenges to primary healthcare. Because what is why we are not able to give successfully primary healthcare to every individual in the periphery? What are the key achievements? What are the challenges we are facing? That has to be addressed. Next is proposed model of comprehensive primary healthcare, CPHC, that is comprehensive primary healthcare to achieve universal health coverage, that is financial risk protection. Here we bought the insurance scheme. So how the model should work for comprehensive primary healthcare to achieve the universal health coverage, and key challenges to comprehensive primary healthcare. So these are the objectives of Ayushman Bharat Yojana. I hope I don't want to much waste your time in rather. This is the healthcare system we have in India. Village level, hospitals. Village level, we have workers, like we have village health committee, we have sanitary health committee, we have self-help groups, we have Mahila Mandals, then we have Anganwadi workers, we have Asha workers. Then comes to your female multipurpose health worker, male, female health supervisor. That is a category we have. Sub-center we have health worker, male and female. When you come to PHC, then we have a medical officer, Ayush, and CSC, medical superintendent. We have certain specialists there. So weekly pediatrician will visit, gynecologist will come, ophthalmologist. We have certain hospitals. So then, if you look at hospital side, we have subdivision hospital as well as a district hospital, regional hospital, specialist teaching hospital, that's a medical colleges. So this is the pattern current healthcare system existing in India. Hope everyone of you are aware. Next is private providers. We have indigenous system medicines. We have informal providers. Indigenous system medicines is like Ayurveda, homeopathy, Unani, Siddha. Informal providers means the religious certain good practices we have. Maybe there is not scientifically proved, but some good informal providers are still available in the community. And we have international agencies working right at Red Cross Society, working very good. We have UNICEF, which is contributing especially in child and women development. I hope this is clear to everyone, healthcare system, because I don't want to talk much about this. Yes, it's clear. Both you are there?
Yes, sir. Clear.
Shall I proceed, or I should again talk about more about this healthcare system?
No, sir, you can proceed.
Okay. Next is the primary healthcare, how it came into force. Again, one of the boosting principles are Board Committee, Almata Declaration, Health for All 2000, National Health Policy 1983, MDGs 2000, National Health Policy 2002, National Rural Health Mission 2005, SDGs, 5-year plans, National Health Missions. This all together led to have National Health Policy 2017, and that all talk about this concept of comprehensive primary health care, that is Ayushman Bharat Yojana. I hope all of you are clear about Ayushman Bharat Yojana now, concept, why it is about, what is the leading force, right? Right from Board Committee till whatever the policies we have, programs we have, MDGs, etc., all together are leading force to bring Ayushman Bharat Yojana, that is comprehensive primary healthcare. Major constraints of primary healthcare was underfunded, ज़्यादा fund नहीं था. Selective healthcare package, all the packages were not available at the periphery for primary healthcare. Lack of financial protection, पैसा नहीं था. There was no money with the government, even with the public. So with that, they come up with the health and wellness centers. Most of you are aware that health and wellness center now it's looking after. Who is the who will be looking after health and wellness centers? In Gujarat, who will be leading the health and wellness centers? It is CHO. Community Health Officer. That's a new the cadre. It is bought by the government of India. And next we have is, which most awaited thing what we all are expecting probably is National Health Protection Scheme. That is of your 5 lakhs of insurance. It is part of comprehensive primary health care. So 2 important things we need to remember for comprehensive primary health care are Ayushman Bharat Yojana is Health and Wellness Center, the establishment of health HWCs, and National Health Protection Schemes. Core component of comprehensive primary healthcare is institution structure and service organization, human resource policies, access to drugs and diagnostics. It is using well-coordinated technologies, ICTs, continuity of care, social determinants of health, community linkage and social mobilization, quality of care, governance and financing. So when you want to give a good primary health care, comprehensive primary care, the most important thing is having a good institutional structure, infrastructure and service organization. You should have a skilled human resources and they should be able to access all the medicines which they prescribe, and all the diagnostic evaluation should be made available at the periphery. They should use integrated, well developed technology. They should be able to give continuity of care, because many times if you go for non-communicable disease, the patients take medicines for a few days, then there will be non-compliance. Especially in TB, we can see non-compliance. Hypertension, many times we can see the non-compliance, and that will adversely affect the situation. So continuity care should be ensured. Social determinants of health, there will be local practices will also determine the health of the community. So we need to identify what are the social determinants are influencing the public health. We need to work on maybe some good practices, maybe there will be some bad practices. We need to analyze, and you need to educate them. Community linkage and the social mobilization. So there are a community, we have to local support is very important. As we said, village health guides we have female depots, we have Anganwadi worker. So there should be linkage and mobilization of those. Then only we can achieve the comprehensive primary health care. And we have to render quality of care, governance and financing. So from where we have a leader, we have to work under the single leader, common leader, and there should be appropriate financing by the government. This is what the core component of comprehensive primary health care. So this is all the institutional structure and organization services. We have sub-center, we have PSC, under that we have primary health center, and the thing what is health and wellness center, and the important role of this public health CHOs, community health officers, is integrated disease surveillance, early identification of the disease, screening of the people. That is what the major role of this, so that we can reduce the risk of disability, risk of rehabilitation, risk of complications can be reduced. Early identification can be done. Planning, location, infrastructure upgrades of health and wellness center. So ensure equitable distribution, travel time to care, and optimal utilization of services. Why we require the health and wellness centers? So we can reduce the travel time for the common people. So they need not to go to PSCs and CSCs for if they need not to travel. There they can go to health and wellness center. So they can utilize proper resources. Incremental approach. So they have CHOs are well connected with the PHCs, right? So there they can refer, they can contact, and they can give the solution to them. Addressing gaps in infrastructure and manpower jointly by health and engineer department, you consult with the primary healthcare team and community. Addressing gaps in infrastructure, manpower jointly by the health and engineering department. So we should develop such a way that infrastructure where people will be more comfortable to seek their services. These are the component of health and wellness center. So that is one is expand the services of delivery. So whatever earlier only Mamta Day they used to run. There are much services were not available. Now many services, all integrated disease surveillance are happening at the health and wellness center. Expanding HR and multitasking, multi-skilling. Then partnership with the knowledge and implementation, community mobilization and health promotion, robust IT system, financing and provider payment reforms, medicines and expanding diagnostic, continuum of care, telehealth and referral. So this is are made available at the health and wellness center. So yet we don't have all the services available at one health and wellness center. They are working well, but soon we may have these all components working at health and wellness center. Expand the range of services is care in pregnancy and childbirth, neonatal and infant healthcare services, primary healthcare and contraceptive and other RCA services, management of communicable disease and national
Excuse me, sir.
health programs, management of communicable disease and patient care for acute simple ailments, screening and prevention control and management of NCDs, care of common ENT and eye problems, basic oral health, elderly and palliative healthcare services, and palliative healthcare services is not well established in India, but still some extent we can give palliative healthcare services. Emergency medical services, screening and basic management of mental health services. These are all the expanded range of services are now taking place at the health and wellness center. I hope everybody are clear.
Yes, sir. So last 5 minutes are remaining for ending
Yeah.
the session.
All right, just give me. Next is the last one I'm going to talk is National Health Protection Schemes, that is Pradhan Mantri Jan Arogya Yojana. So which is very the day step government has taken. So they have health insurance cover of 5 lakh per family per year on floating basis. Remember, and it envisages of financial protection from catastrophic health expenses to 10.7% crore rural or urban poor families. So extra additional benefit is given to them, and coverage almost all the secondary and majority of tertiary case procedures. All the surgeries and diseases are covered under this, and even private hospitals are empaneled. You can Google and search in your areas. Without any cap of family size, as people are thinking only 4 members, 5 members, no cap on the family size or any age. Everybody are able to access it, right? And cover all pre-existing diseases. So in the conclusion, I have patient and public have right to receive the best treatment and services from healthcare professionals, and this can only be achieved by the motivated, well-prepared workforce. Suffering to the requirement of nurses and facing the challenges can make nurses empowered, encourage and challenge and affirm to continue excel to do the best without any barriers. So whatever we talk about policies, programs, everything, and nurses are the backbone. So they are when their force is very important, it cannot be ignored. So we have a lot to do with the programs. So that is my conclusion. I have two acknowledgement. Most few of the contents I have borrowed from Rakesh Patel, Taluk Health Officer Professor. And next we have Professor Shani Sata, is my wife, and she contributed, a few of the things she got me and helped me to prepare this content. So these are all the reference I have. So with this, I am concluding my topic, and again I appreciate Dinesh Patel College of Nursing, such an enthusiasm. They keep organizing such events very oftenly, and I think this is the only institution in Gujarat, independent institution in Gujarat, had NAC accreditation. So that shows their commitment towards equality of education. I really appreciate the management. Professor Virendra Jain, sir, principal, is my friend too. Then very active and young Kailash Nagas and Jodh and whole team. I appreciate and thank you so much for giving me this support. That's it from my side.
Thank you so much, sir, for such an informative session. Really, we have upgraded our knowledge in the health policies and the health programs in the community health nursing. If anyone wants to ask any doubt or have any questions, then now it's time you can ask the question to sir. Okay, so now we will move again with our next session. The introduction of sir we have already seen previously, but in short, I will tell that we are going to start with our second session of Mr. Irana Kajakar sir. Sir is working at present in PP Savani School of Nursing in Surat, and he is specialized in community health nursing. So now over to you, sir.
Okay, once again, thank you for the introduction, madam. Jodh sir, kindly share my PPT. Madam, is I am audible?
Yes, sir. We are able to hear you.
Yes, that's good. Sir, kindly share the PPT.
Yes, sir. We are sharing it.
Okay, once again, good afternoon to all. Yes, sir. Next slide. Next slide, sir. Next slide. So today's allotted topic for me is that community health nursing towards the sustainable health. So as we all know that good health is very, very important for the development of the country as well as the family and to the society. So we have already seen the definition of health, that is complete state of physical, mental, and social well-being. So we should be well-being in all their three aspects. So by seeing that health definition, we can say that health is heavily influenced by the factors of outside the domains of the health sector, especially the social, economical, and the political forces. So next slide. Thus, we can say that the attainment of the highest possible standards of health, it is depends upon the comprehensive, holistic approach, and which goes beyond our traditional curative care, involving the communities, healthcare providers. So, whole and soul, the optimum level of the health maintained by the community, it depends upon that all aspects. So let us see what is that community health. We can say that community health is a medical practice which always focus on the people's well-being in a particular geographical area. Next slide. So as I told that sustainable health is nothing but maintaining the optimum level of health of the particular family and the community and also country. We should try to avoid that all the health problems, health related illnesses in our day-to-day life in the community, family, and to the society. Next. So as we have that sustainable development goals, we have 17 goals. We need to reach it by around in the year of 2030. So in that the third goal is to help good health and the well-being. So to reach these goals, we need to work hard. Especially the community health nurse or the health profession or the nursing profession has to work hard and to plan new healthcare delivery systems, okay, and to actively participate to control all that health problems. So it is a very important task for the community health. Next slide. Next slide. Okay. So what is needed to achieve it? So previous slide, sir. Previous slide. So as I told that. So to achieve this, we need a strong health system. Okay, to need a strong, efficient health system. So that health system should provide all the healthcare services to the needy people, and it should reach to the ground level, to the high level. It should reach to each and every people. So as sir told that, like universal health coverage. So whatever the health services are there, that should reach to each and every person. So that kind of health system should be needed. The next one is whatever the health services are there, that should offer to each and everyone, and that should reach to everyone. Next one is it is available to each and every person. Easily it should access, it should access like medicines or the technologies, or to diagnose some kind of diseases, or to treat some of the health problems which the population or the people are suffering. Next slide, sir. So also we should have that well-trained, motivated health workers. So we require a manpower to reach the optimum level of the health. So in that health workers or the manpower, so definitely our community health nurses plays very vital role to prevent all that kind of health problems and to handle the crucial situations which is occurring in day-to-day in our community. Next one is we should have that social determinants, like we need a supportive staff, like we need a proper education, okay, and we should have that living condition and the household and proper income of the particular people. They should have that proper job, and to they should be economically stable to control their health problems. Next, sir. So when you see this, when speaking regarding the community health nursing, so let us see what is that community health. So as we all know that community health nursing is a synthesis of nursing and the public health practice, so which can be applied to promote and protect the health of the population. So it combines all that basic skills or the basic elements of the professions which we have learned. Also, it applies all that clinical skills, clinical nursing skills, what we have learned throughout our profession. So all that skills can be applied in the community level just to control all that kind of health problems, to identify the health problems, and to fulfill the needs of the community people. Next, next slide. So since from the last 10 years, the community health nursing is emerging like anything because we are facing many of the changes, changes in the demography, changes in the diversity, changes in the technologies. We are facing so many advanced technologies, and we are facing recently we have faced a COVID pandemic. In that, the community health nurse has shown his skill and his effort, and they achieve to control these kind of health problems. Many of the nurses they have sacrificed their life to contribute against to the community health. Next. So always the community health nursing focus on the human resource requirement, that is bringing the manpower or educating the people. Okay. And next one is to access the healthcare service. So whatever the health services are there, that should reach to easily to the community people. So our community health nurses are taking the health services to their doorsteps. Okay. If they are in the need of any kind of health services, this community health nurses and our community nursing profession is taking the services to their doorstep, and management of all that reforms, and always they try to participate with other community people. They try to mingle with or try to involve the other departments or the community people or the youth people or any other departments to plan and to solve the other health problems which is related to that particular community. And also it help we focus on accessing to the medicine, whatever the medicines or whatever the health services are there, that should reach to the community people. Next. So we have like some additional focuses, like we focus on the urban health, try to maintain or to maintain the optimum level of health. And we focus on the female gender, that is bringing the equality. Okay. And public private partnership. And next thing is information technology. Always uh, we are focusing to adjust with the changing technologies in the healthcare system. And finally, we can able to provide all that health services. We focus on provide healthcare services which is intended for the community people. Next. So who is the community health nurse? So when you speak regarding this, all his activities and all, so who is he or who is he? So community health nurse is what? He is or she is a registered nurse who is specialized in a promoting health for the diverse communities or the infant, children, or the adolescents and the adults. So these who are working for the welfare of the community, providing all the services, and he should be registered. So the nurses are having a multiple task or the multiple role. So they work as a can work in the community care centers. They can work in the mental health addiction centers. Then they can work as a palliative nurse. Okay, healthcare educator. Okay, then they can work as a public health nurse. So they have a multiple task, and they have a much more scope to provide the healthcare services to the needy people. The next. So what is the important or what is the value of the community health nursing now in the current scenario? So community health nursing provides care in many settings. It is not like that only we are stagnant or only we are stick to the primary health center or we are stick to the only to the hospitals. No, we are providing the care in all the settings. We can the settings like clinical faith-based settings, homeless shelters, or the schools. So they are the primarily concerned with meeting the public needs of the people. We are the first community health nurse, the first person to go and approach to their needs and to identify their problems. Community health nursing works with the diverse partners and the healthcare providers in the communities and can effectively contribute towards maintaining the optimum level of the health. Next. So what is our the objective of the community health nurse for maintaining this sustainable health? First one is to participate in all the development of overall health plans for the community. Whatever the health plans are there, so just you need to participate and try to implement that all the developmental plans. And next thing is to provide the quality nursing services to the people. Wherever it is needed, you provide the services. If anyone need regarding the antenatal care, you provide it. If anyone need the immunization, just provide it. So like it, there are a number of services are there. So just try to provide that all the services. Next, our objective is to coordinate the nursing services with various members of the health team. So we health team, we work with the health team. So just we need to coordinate with them to bring the new ideas or to bring the new plans or to conduct the camps, okay, or to provide the services or to identify the health problems. So we need to have a coordination with the other team members also. Next thing is we can able to participate or the conduct research relevant to the community. So nowadays research is developing like anything. So we should have that object to bring the new things in the community area, try to do the research studies and try to involve in the projects which is sponsored by the central government or the state government. So let us make changes. Let us bring some changes in our services or in the community health setting. Next. So here you can see that the community health nursing interventions towards that maintaining the level. So our services or our interventions in the health promotion. So in the health promotions, we try to promote the health of the people, community people. In that, it can be done through the help of the education. We are bringing the awareness to the people, but through the help of the education, we are bringing the what is the importance of the health. It can be make them aware of the people through the help of the educational medias. Okay, then we can do some counseling wherever it is needed. We do the counseling and try to bring in a right track. Then next thing is we can do the provision of support tools. Okay, the next one is we can do a community mobilization. Next one is we can work in the area like disease prevention. So we can able to identify that, do the health assessment, risk assessment, do a thorough assessment, try to identify the diseases, okay, try to diagnose the health problems, then do a screening camp, okay, do a screening. Early identification is very important. Conduct a screening camp, okay, try to identify the health problems in the early stage. Next one is the treatment. Wherever it is needed, the treatment is needed, you provide a optimum level of, you provide a comprehensive nursing care related to the health needs. Next one is to manage the diseases. So there we can able to manage the disease wherever if they are suffering with some kind of a disease, we try to manage them, provide the care to the patient, pay to the people. Either you can go to their home or either we can take the people to the community area. Next one is care coordination, then care provision that includes the patient monitoring, treatment, and the counseling. So we need to monitor the patients if they are undergone some treatment, if they are undergone some drugs. Okay, so we need to monitor. Finally, we can help them in the rehabilitation. Other than this, we can have a some of the administrative interventions also. We can able to manage some of the policies. Also, we can help to develop the new policies. Okay, we can use our ideas, we can give our plannings, and also we can evaluate the current health plans. Okay, current strategies or the current health program. So if there is any modification or any changes, we can is there means it is needed means we can able to suggest to the concerned people. Then we can able to supporting the development and implementing the effectiveness of national response in accordance with the national contents need of the priorities. Okay, next. So these all are the scenarios, these all are the problems where we can able to see in the home. Like we can see a widow who is suffering from the depression, or a mother who is just delivered a child in the home. Okay, she needs the care. So there we are approaching our care to the community. Like that, there are some of the scenarios, home scenarios, like we may find a amputated elderly man with the diabetes alone. He's staying alone. Definitely, he'll be in the need of the care. So in these all the scenarios, as a nurse, as a community health nurse, we are providing whatever the care they need. So with that we can able to maintain the optimum level of the health of the people and the community. So these are the home scenarios. When we visit to the home, definitely we'll have these kind of problems, and we can see, can identify these kind of problems in the home setting. Next. So we also we have a very vital role towards to maintain this optimum level of health or the sustained health. So community health nursing practice in a variety of settings. So we are practicing in a different setting. As I told that we are working in the schools, we are working in the other settings. And community health is again re-emerging as the integral part of the providing care to everyone. Yes, we are re-emerging. Yes, the community health nursing is very essential nowadays because we are providing the doorstep services to them. Next. Sir, next. So role of community health nurse is particularly important in developing countries like India, definitely, because large section of community is not able to access the hospital or the health infrastructure. So it is very important, like a large country like us, it is very important that each and every person cannot approach or cannot reach to the hospital. Okay, it cannot be accessible for them. So there what we have to do, we have to perform our role, and we can able to provide the health services to their doorstep. So next. So we have all the roles to maintain the sustainable health or to optimal level of health. Like we can act as advocate, we can stand with the community people, and we can able to aware them, and we can able to help them, and we can tell them that what is their rights towards the health. Okay, and we can stand with them, and we can make them to get all the services which they are in the need. Next one is we can perform a role like clinical nurse. So there we can provide all the services which the community people needed. Like same thing, like we can have a role of care manager, case finder. Okay, we can able to find the new cases. Okay, we can do a survey in a community sector, and we can able to find the new cases. And next one is we can become a good counselor. We can able to counsel the many people. Those are having health problems, and they have a confusion to identify their health problems and to choose the health services. Next one is we can perform a role of epidemiologist just to find out the cause of the health problems which is arise in the particular community area. Next one, you can perform a role of group leader whenever we are leading the task or leading the programs, health programs or the camps. There we can perform a group leader. We need to advise, and we need to instruct, and we need to monitor, and we need to guide other health team members, those who are working for that particular programs. Next one is we can perform a role of health planner. We can able to plan the new health activities which is needed for the community people to control that all health. Same thing like we can perform a role of home minister to handle that all the home scenario problems. Then we can perform a role of occupational health nurse. And next thing is researcher. As I told that research has been developed more, and it is nowadays it is very important to find the new things in the field of nursing. So there also she perform a role of researcher. Then school nurse, there she takes take care of that all school children. They identify their health problems, and she perform the referrals. She give the referral to the other hospital to try to control that health problems. Next one is she perform as a teacher. Yes, health education is the main strategy for our community health nurse. There she provide proper health education to the needy people. Next. So these are the roles she perform to control or to maintain that optimum level of the health or the sustained health. Other than this, also she have that all the interventions or all the activities she will carry during her day-to-day life or during her time. So first thing is she promote healthy lifestyle to the community people, and she work for preventing the disease and all the health problems which is emerging in that particular community. and she provides a direct care wherever she goes to the community or wherever she goes to the houses, wherever she identify the health problems or the community people, she provide all that direct care to the needy people. Along with that, she will educate the community about managing chronic diseases and making healthy choices. So chronic diseases are one of the burden for one of the health problem for our country. So she tried to evaluate that all the all the health problems which is arising. Next one is Institute Health and Wellness Programs. It participates and conduct research to improve the healthcare system. Next. Other than this, she tried to control all that infectious and sexually transmitted diseases. She makes the awareness, she brings the awareness. Okay, she tried to remove that stigma. Okay, among the that sexually transmitted disease and whatever the false beliefs which they have with the diseases like AIDS and hepatitis. So she tried to remove that all things. And next one is obesity. Nowadays, the people are addicting to the junk food. Okay, so with that may cause the obesity. So she tried to avoid that obesity. And next one is she tries to make the people to eat a healthy nutrition. So she participate in the nutrition programs. Okay, and she implement and she motivate for and she guide for that midday meal program. Same thing like she tried to avoid that substance abuse, so smoking. Okay, and wherever it is required, she provides all the health education. Next thing is environment is part of our community. So always she plans or she monitors our environment and to ensure that safe environment in the community. And next thing is immunization is the vital immunization is the vital health services. So there we see the community health nurse will participate and she identify who are in the need of immunization and she provide the immunization and she participate in the immunization camp. And the policy reformers and next one she work for the community development. Next. So we should have that strategies towards the sustainable health. What is the strategy? Next. We should have that without education we cannot achieve this sustainable health. So we should have that educational programs and awareness programs. Okay, it is only possible by giving the education and awareing the people regarding the health. What are the importance of health? Okay, what are the emerging diseases? What are the non-communicable diseases? How we have to maintain our lifestyle? So regarding these all things, we need to provide the health education. So with a different media, we can able to provide them health education. The next. So we can work with the community level just to promote the healthy living. So it helps the to prevent the health problems and brings the greatest health benefits to the greatest number of people in the need. So always community health is mainly depends upon the individual wellness. Community health nurse puts the health people. So we should try to control. So starting from the individual, if you keep the individual healthy, definitely the family will be healthy. If you keep the family healthy, definitely the community will be healthy. If you keep the healthy community, then definitely society and as well as our country will be healthy. So looking after from you target the individual, target the family, and then you target the whole community. So you should, as I told that, the community should be targeted. If you are, we should have, if you have a lack of focus on the community health, that will lead to range of complex and problems which cannot be corrected very easily. So we should target that community health. Always you should try to maintain that good community health, and we can able to maintain the optimum level of the people. Next. So the last one is we can able to control that chronic disease. So chronic disease is one of the major health problems. So 90% of the national's annual healthcare expense we are spending it for these all the chronic health diseases. It is very important for the community health nurse to control these kind of chronic disease with the help of the health education, with the help of the providing all the services which the government is providing, making the awareness, Okay, so like this we can make and you can implement these all the strategies to maintain the sustainable health. Yes. Next. So by this I can able to conclude that community health care, wellness and disease prevention must be occur at all the level of the healthcare in order to maintain the sustainable health. So finally I can say that community health nursing plays a vital role towards this maintaining health. So to prevent all these health problems or to maintain the sustainable health, so the community health nurse is a very, very important player in this profession. Okay. So with this, I would like to conclude. Okay. So again, I would like to extend my sincere thanks to Dinsha Patel College of Nursing, Principal Virendra sir. Okay. And Joy. Okay. So I would like to extend my sincere thanks to you. Thank you very much.
Thank you so much, sir, for sharing your best knowledge with us, and we are surely upgraded with this topic. If anyone wants to ask any questions, then you are free to ask, sir. Okay, thank you once again, sir. Now for imparting the conclusion, I request Mr. Jyot Darji, sir, nursing tutor of Dinsha Patel College of Nursing, to propose the vote of thanks.
Good afternoon to all the respected dignitaries and the delegates. It's my pleasure to present the vote of thanks of this e-conference on recent trends in community health nursing organized by IQSC and the Community Health Nursing Department. First, I am heartily thankful to the management of Mahagujarat Medical Society for enabling the conference with the constant support. I would like to convey my sincere gratitude to Dr. B.S. Salas, sir, Director, Dinsha Patel College of Nursing, for your continuous guidance and support as a backbone of this conference. Thank you, sir. I would like to express my deep gratitude to Mr. Sidram Sarate, sir, HOD Community Health Nursing, MTIN Charusat Changa, and Mr. Inana Kajagar, sir, HOD Community Health Nursing, PP Savani, School of Nursing, for sparing your valuable time, busy schedule, and accepting our invitation to share your knowledge and be a part of this conference. Thank you so much, sir. I would like to express our sincere thanks to Principal Sir, Dinsha Patel College of Nursing. I would like to convey my sincere thanks to Ms. Arpita Vaidya ma'am, Vice Principal, Dinsha Patel College of Nursing. I am thankful to Mr. Kailas Nagar sir, Organizing Secretary and HOD of Community Health Nursing, for minute-to-minute planning and tireless effort to make this conference successful. Here I would like to thank all the community health nursing members for their support. Must mention a hearty thank to all the nursing family for excellence and response. A big thank to all the delegates who joined this conference. I would also like to thank organizing committee members, non-teaching staff, students. Without your participation and the great support, this conference cannot achieve a high standard of this success. My special thanks to technical committee for making this conference on virtual mode. Last but not least, I thank Miss Angel Christian, MSc Nursing Tutor, Community Health Nursing Department, for their perfect anchoring in this conference. Once again, I thank you everyone for the contributing in this e-conference. Thank you.
Thank you, sir, once again. Here we are ending with this conference. Thank you once again.
The e-certificate will be provided within 1 week. Thank you.